Nous poursuivons cet après-midi malgré le soleil.
So we're going to kick off this afternoon with a second theme. Should we industrialize healthcare production with Philippe Durand, Pierre Dehaas, Monique Roman, Sylvie François, and the moderator will be Thomas London. If you'd like to come and take a seat, please. So we're going to be able to now, start the video. Should we industrialize the production of healthcare? It's 9 p.m. in Dr. John Edward Overwork's surgery. This GP has been treating his patients one after the other all day. This morning, he diagnosed a bacterial meningitis in a little 7-year-old girl, undoubtedly saving her life. But right now, after finishing up all his paperwork, he still needs to sweep the office. Indeed, just like more than 1 out of every 10 doctors, Dr. Overworked also does the cleaning in his office. After 9 years studying and 10 years of practice, he's still washing the floor himself before closing up. You can be an excellent doctor and still be a terrible manager. Some have a conception of the production of care that reflects their training as medical professionals. They leave medical school with a knowledge of the rarest and most serious diseases and yet find it insurmountable to hire a cleaner or a secretary. Trapped in a logic of income versus expenditure, doctors don't consider investments the way the rest of society does. And 2/3 of them, for example, don't even accept credit cards. Not to mention the poor use of information systems. What French doctor's office is able to draw up a list of patients who are up to date with their vaccinations? The expression to industrialize the production of care makes people frown as they imagine robots taking over. And yet it is the best way to promote an efficient organization of patient care by actors who can then focus on their core activity. People in disorganized hospitals keep saying that we must hire more professionals, and yet they forget that in the last 30 years, the number of doctors in the French public hospitals have tripled without improving the situation. There are more and more nurses, and yet everyone is still complaining. In hospitals as well as private practices, the industrialization of care would undoubtedly have a better reception if it were believed to meet the ultimate need that both doctors and patients can agree on: to give healthcare professionals more time to devote to actual care. So there we are. That's the context of the debate. Hello, everybody. I'm delighted to be moderating the debate for the next 45 minutes. As the film underlines, for many economic sectors, moving on to industrial logic has improved productivity. In other words, improving costs and the resources that we need to invest in a process in order to produce a result. But also, and we'll come back to this later, it's made it possible to improve quality and the result that we obtain with a given set of resources. An English study a few years ago talked about the level of risk dying in hospital. And it was like jumping with elastic ropes or going up a mountain as a climber. So we've got to look at productivity and industrialization and reduction of variability. And that's the question. So just to launch the debate, I'm going to turn to Philippe. This notion of industrializing production, does it apply to the production of healthcare? Should it apply to the production of healthcare? So, well, let's think about the principles. Yes, I believe that that is the case. As you've said in your introduction, it's these industrialization principles and organization principles that have led us to rationalize the productivity of other industries across the world. So why not apply these principles to healthcare? Now, why not to healthcare? Well, healthcare is more complex. So the answer is yes, but here we are in the Arve Valley. Here's an example from industry. There are many industries in this valley, metallurgical industries. You've got metal sheets that arrive in a factory, they're cut up, they're stamped and transformed, and then You have a finished product that's shipped off to the customer, and all of that under the management of the general director. In healthcare, we carry out diagnoses, millions of diagnoses. We carry out a lot of treatment, a lot of monitoring. We send the patient back home, and all of that without any real governance of what's happening to the patient's care path. Now, there's two differences between industry and our sector of activity. The first is that there is no real boss when it comes to the patient's healthcare pathway. And the second is that we're not dealing with metal sheets. And so there are human interactions between each stage on the pathway, with a result at the end of the pathway. So between diagnosis and treatment, you meet different people, you go on the internet, and you realize the diagnosis, the treatment, well, maybe it's not the right kind of diagnosis and treatment. So there's a lot of challenging because there's no bill of materials like in many industries. So a lot of people's imagination runs away with themselves. Now, one of the points is that this is a very complex process. You have the acts that are involved, and then you have the actors involved. Can we not apply this notion of industrialization, or should we really be applying it? Let me give you an example. We've talked about this term, industrialization. It's something that's frightening for medicine and organization as well. We had a problem. I live in the north. 20% of the population is obese in the north. And 12 years ago, there was no visible offer for patients. There was nothing for patients who were obese, aside from surgery. So there was no access to healthcare. Our objective, therefore, was to try and develop access to healthcare for these patients. It was about 10 years ago or so. And so we set up a group of professionals in the region, and we started to think about what was necessary. And as of then, we set up a specific kind of organization, an organization that was based on 3 levels. You need a boss. We didn't have a boss because it was something that had been co-built, but there was coordination that was in charge of assessment, a coordination that contributed to setting up the specifications for obese patients. And each healthcare professional was remunerated according to the specification. So there was a central organization, and it was also based on regions, on local areas. So for each area, there was a specialized center. And then the center worked locally to set up education actions. So this organization was set up, and then there were quality requirements in line with the specifications that had been drawn up by all of the people involved, and then remuneration based on that quality, and also training where everybody came together. So that's just one example, an example of industrialization, but although we didn't refer to it as industrialization. Do we have any other examples for private practices, for example? We had the film that talked about this. It's difficult to add something to this. It was fairly based on caricature. But yes, you can have industrialization in primary care. There are different examples. So there's the idea of rationalization rather than mechanization. This morning we heard that we need a lot of common sense, and we were comparing healthcare to cooking. It's something like that, if you like. But in companies, this is the way things are going. But of course, managers change their activity every 5 minutes. And it's like doctors. They change their activity. Even the consultation lasts for 50 minutes on average. They change their activities. They do different things. So there's something that we can do in terms of industrializing what doctors do. You can think about information systems, for example. Any kind of service company spends 10 to 15% of its turnover on the information systems. In primary care, it's less than 1% of the expense that is spent on information systems. So there's a big gap with respect to what can be done today. There are MOTs that are in the car sector. Why can't we have the same thing for vaccines? So there are things that can be improved. We can improve quality. We need to set up the means for this efficiency. Another example is that of protocols. So you are a GP, you treat a patient who's off for 6 weeks with a lumbalgia. it becomes chronic. If ever you say something that's contradicted by the pharmacist or a physiotherapy or something relating to the belt that you prescribe, then things start to get out of hand. So it's very important to coordinate what we're doing in terms of processes and protocols and consultation, so we can certainly improve quality for the patient. There are many, many examples like this, and I think that industrialization would certainly be beneficial for the quality of healthcare.
Okay. Often, when we start talking about industrialization for healthcare, we often want to compare this with personalization or customization. The healthcare must be personalized or customized. It must be adapted to each patient. Is there actually a contradiction? Or on the contrary, we can imagine having both of these things. So I'm going to talk about the post offices and not about medicine. So that's where we're transforming a very large company. The post office is 260,000 employees. It's 11.8 billion letters and parcels distributed throughout the year. Almost 12 billion operations are run each year. It's a lot of other things too, but I'm going to concentrate on these things. And it's a service that began a very long time ago, back in the time of Louis XI, on a very individual basis, in a very individual relationship. And over the years, when we have 12 billion to deliver, of course, we've obviously industrialized, and we're going to stay that way. We can't do it otherwise. And it's essential in order to succeed with our for things to go as easily as they do in the mail. But as we need to reinvent ourselves, since we're being affected by digital technology and by the decline in the number of shipments through the mails, we wanted to build on our values and the history and the local relationship and service, the service rendered to the customer. And now we're combining industrialization, industrial processes, and interpersonal relationships. Just to give you an example, we ask the mailmen, as part of their rounds, for all the customers who would like this, we ask them to take part in the monitoring operation for seniors at home. And it's called Watching Over My Parents, and which involves having the person come by with a somewhat standardized function. It's industrial, yes, to a certain extent, but as part of an individual and personal relationship at the person's house in order to pay attention to the situation of this person. Whom we're keeping an eye on, and warning the parents or the social services or the local communities who wants to have this service. And we also think, to answer your question, industrialization and individual relationship and service relationship and the quality of this relationship, not only are they not incompatible, but they are absolutely link up perfectly, and there are a lot of conditions for getting there. Can I go on for a bit longer? Yes, thank you. It's not, of course, not easy to do. This assumes a change in the way that the mailmen work. It presupposes a change in our organizational methods and our standards in order to give way. To make some room for this, we have to manage a change on a cultural level and training and skills. This presupposes that we have to equip these people. So we've put together training programs that are quite burdensome, including with physicians, with psychologists, with specialists in managing in gerontology. We don't want to do medicine, of course. We're not doing social monitoring. That's not our job. But just to identify a certain number of signs, and then we pass on this information. So training, equipment, and here you're going to think you don't have to think about the equipment too much, or about training with the equipment, but when we want to mix industrial and personal service, based on digital technology, we quickly realize that not everyone is familiar with the usage of digital tools. It's true for us because 50% of mailmen don't have computers, not even at home. So we equipped and we trained. And this morning I heard people talking about the appraisals, customer appraisals, customer assessments. We went from being the only from monitoring just the quality of the processes, and the process quality was making sure that the letter is correctly distributed in D+1. So we monitor the statistics, and we're at 95 or 96%. But that's not why a customer is necessarily happy. And so we also wanted to, while maintaining this quality, we also wanted to, what we call in companies, we wanted to go to the Net Promoter Score. We wanted to ask the customer what they think of the service that was provided to them, and if the customer would recommend the service. And we also put together with the mailman and to determine how we were going to assess the quality of the service that they're providing. So we started listing a few ingredients for the industrialization. But let's look again at the health world. In your view, what would be the essential ingredients that we would have to bring together in order to succeed with this effort? It's almost the same. We talked about training. It's training. It's important. Training is important. It's also organization. Each person has to know what this person's role within the organization is, and it has to correspond with what they want to do and with this person's vision. So it requires a kind of cooperation. And of course, there has to be certain recognition and also a financial recognition. Now, we talked about appraisals, and you mentioned that, and you mentioned it also. In concrete terms, in health, do we currently have means and tools to perform this appraisal, if not necessarily systematically, or not? Or do we have to go further than what we have today? Not always. And we have to help people to go further. It's one of the main advantages of this industry, with the little hiccups that we've seen or that we all mentioned. We talked about the analysis of results this morning. It's undeniably that's what we have to do. That's what we have to measure. We have to get measurements and analysis. And we're starting to have some very interesting examples with digital tools, where patients can report once they're at their home to continue communicating with the healthcare team, to say something is hurting, if things going well, and to call for help if necessary. It's very, very appreciated by patients. So, yes, there are tools that we can implement. It's also a lot of training, as you were saying, around the specifications. I think it's in the heads that this happens, in people's minds, and then it's going to go into actions. So we've prepared specifications for recovering patients, for treating patients. That starts with the diagnostic, and it goes right through to their follow-up at home. It has to do a lot with the commitment of the teams around these specifications. Is there an impact? Has there been an impact on the results and on how it's perceived by the personnel? Well, yes, very positive impacts. And we'll come back to the idea of customization. Some of our establishments have had partial colon ablation with return home on the day or day +1. So, and the digital tools for monitoring at home. And I've met people in charge of these programs, and people are very happy, and so are the patients, because it also saves them time in order to call patients and to concentrate on other patients who've had to stay in the clinic or hospital because they were more complex, or they needed more treatment, or for one reason or another, or they didn't have familiarity with the technology. And if the patients are happy because they have this constant contact, they know that they can go home. In fact, most of them would prefer to stay home anyways, rather than staying. So we've had these specifications shared with the patients as well. So the teams are trained; they're committed to these specifications for quick recovery, because the patient has become an actor, and so they're very pleased. We've sort of done a school, a university for patients, and it aligns perfectly well with the customization. Pierre, and in local medicine, what do you think? In the primary tools, we're starting to have tools finally, where some of us are working to improve them. We want to improve the specifications as well, but it's also training that's lacking. As we explained earlier, Some medical schools, they teach how to follow up the pathology over time. They're focusing on the patients immediately. They have a short-term attitude. I'll deal with the patient today, treat him today, and that's it. And I don't have to worry about continuity. So if you see a student, who's going to see several conjunctivitis patients during the day, he'll start to think, what's going on upstream? But we don't have that currently right now on the arterial indicators or other. So there's always a great deal of training that's needs. But we have some delay with regard to certain clinics because in the production of primary care, we see people who are still in training who use their time that have no capital, don't have any added value. It's not just the doctors, but this is the reality for a lot of trades. A lot of nurses have a lot of very advanced education, and yet their compensation dates back to the early days of the 20th century to refocus professionals on things that have more of a financial added value. I just wanted to add to something here. I work for a Swedish company, and we manage 50 or so healthcare centers. We have just launched an online consultation system because it's authorized in Sweden in order to facilitate access to our healthcare units. So the first 100 parents are still very modest with their figures and things. So we can't be, but we have 90% of these initial ones. We've eliminated 90% of physical consultations. So 90% of the 90% of the people who come in, who should have come to physically to one of our facilities, have not had to, with all of the safety and sustainable development aspects that has. Just to stress that fact, the level of productivity, the sources of productivity that we can have, and quality and interest for the practitioner as well. So you're going from the patient, you're making the patient an actor. In industrialization, a patient is not a thing. It's going to be an actor, but one who's trained and knowledgeable, and he's also going to train other people. It's also going to help to train medicines. You can learn a lot from patients, and I think that this is a very important role for them. We're all working on the same level, but we're all part of this process together. All the more so since they have a tendency to get information and to be proactive in the management of their pathology, and also they have this tend. And it was patients often who train physicians by giving them a background. You've insisted a lot on this idea of mentality and training, as though the tools and the protocols were no longer a subject. Is that true, or is it still a subject? Are there still things to be developed? I won't speak specifically about medicine, but the tools are of course a subject. When we industrialize, or when we develop services that are individualized by using everything that digital technology can offer, we have to make sure that it's simple. Simple for the user, for the physician, simple for the patient as well, I imagine, and simple for us as well. You can be certain about that. Even though it isn't natural. It's not natural. When you take products or when you design products, when the technologists design them, it's not simple right from the start. There's a lot of reflection is needed and to build and to reflect. The second reflection I heard people speaking about a lack of reflection on patients who have come in and have the same pathology. And I was thinking to myself, in France, there's a large database, very large database, that you doubtlessly know, that we manage. That's a database by one of our subsidiaries, Doka Post, and manages health data people for 45 million of our co-citizens in France. We manage that, the health and pharmaceutical information for these 45 million French people. So I know what the uses of this database are and what they could be. But I'm not sure that we've derived all the possible uses in the territories outside of the big cities, over and above the usage very global, or the usage on face-to-face on the pharmacist, between the pharmacist and the patient who comes to see him. Why are we still asking this question? Should we industrialize healthcare? Because the car industry wouldn't ask about that. Because what you're saying is that it's an obligation. It's something. It's indispensable. Why do we keep asking the question and debating it in 2017? What are the barriers that we have to that are stopping us from going slower? It's not in our culture. Healthcare and medicine. It was the medicines on one side, the patients on the other side. There was the hospital and the city, and everything. It still works in silos, even though the barriers are starting to open up. We still have a lot of barriers that prevent. In fact, this industrialization involves everyone, and we would have to knock down the barriers. When you're in a company, there may be barriers, but there's an organization, a common organization. Here, there isn't. We have 50 different organizations. We have prevention, we have care, we have financing, we have all kinds of different things. Everything is different, so it's very difficult. And also, physicians have not been trained to work together with others in this way. So of course, things are going to have to change, but it's going to change slowly. Then that's why our choice is very easy. We were going to start with the people and the organizations. We have to develop culture. We're not asking about industrialization right now, but most people today, most stakeholders agree that it's the right trend to be looking in this direction. However, it's really the how, and this is where we compare with other sectors. And we have a tendency to work together with our I know I've been in this sector 15 years, and it's hard to break out of it and to look elsewhere. It's important to develop the culture of the people. And we agree with you. It's important to create specifications that are multidisciplinary around the patient, as the boss was saying, chef in the boss industry and in the workshop. But I think that in our case, the boss shouldn't be the boss of the workshop. It should be the patient. It's the patient who should assess us. It's the patient who should be able to report on, give us opinion on their satisfaction. There's a lot that we can do. So there's the people. We have to develop the culture. The organizations, they're going to have to be aligned on which we're obtaining a commitment of the men and the women. There's a lot of training. We have to talk about that. And job descriptions that are changing, they're radically changing. And then, as soon as possible, we have to change the tools. Once people have the training, and then we have to roll out the tools. And digital technology is helping us to do this. The customer follow-up before, during, and after treatment is growing considerably. And we'll be able to do even more and develop more quickly in this subject in terms of efficiency. So we're going to give the patient the keys to the vehicle. We mustn't be afraid of that. This morning, Gregory was saying we mustn't be afraid of analyzing the results because that's how we're going to improve, and that applies 100% of the time. And there's 100%. I would say the same thing for the patient. We mustn't be afraid of the patient. Quite the contrary. Quite the contrary. I think that in the barriers, there's what you said. There's a hindrance to change for the organizations and for professionals who have a certain economic consideration. They have to manage their spending and and how they operate. We can't put them at risk, and since they don't necessarily have a map, they can say, "I know what I have now, but I don't know what I won't have in the future." So all the imagining that goes around that. If you talk about a doctor or a nurse. Instead of looking at a young person, a woman who's using a computer system, we have to change the imagery. We have a lot of trouble advancing with change. And the other barrier today, in an economic level, it's not the sector, namely the industrialization of primary healthcare. There's no assistance here. In recent years, we've devoted 100 billion euros in health centers. Okay, it's great for the walls. It's great for the building companies, and it's fine for certain healthcare workers who. But what do they change? in the industrialization of the system? Not much. And we're going to put another 500 million in there. So we hope that these 500 million euros are going to be used more intelligently. For example, so I have a company that manages this, and there's only 2 of us in France, or 3 next week. This sector is so complex. There was a call for innovation that allowed us to start up. So there's been a lot of data innovation in recent years. So here's an essential element in the future, which is the organization of primary care, the industrialization, the modernization for quality. We're going to prepare some specifications, and we're going to call for innovation.
Another thing is that we're faced with private practice doctors, and they have a problem with VAT at 20%. If you hire a secretary, it's just as expensive as if you hire a secretary from Manpower. They're going to have to pay the VAT. So we're going to have to think about, in economic terms, how we can help healthcare professionals. If they're purchasing services such as these, it might be complicated for them. We could imagine systems of delegation. Delegation, it's not public service delegation, but real delegations by the French state. But then that would be a very strong policy message. If we have someone who says medicine of the 21st century can no longer be practiced this way and imposes specifications on us with some of these conventional agreement frameworks, we've just invested 26 million euros in these conventional framework agreements. Well, it's sort of a drop of water in the bucket, if you will. But in terms of the reorganization of the system, it is a drop of water in the bucket. So I think the politicians are not ambitious enough, and we need something stronger if we really want to move away from this system, which is economically balanced, and take the risk of really fundamentally changing the system. And I totally agree with you. I think the debate is opening up concerning primary care. If we're going to invest more money to replicate identically or pseudo-identically, bring together practitioners doing the same thing, there's no point. We saw this earlier with online doctors' consults. I think we really need to open this up, this possibility. There are some countries doing it. Why don't we do it yet? We really need to challenge ourselves on this. I can't reach my GP on the telephone because he's totally overworked. So if we take the Swedish example, how can you explain that in private practice, doctors, Swedish doctors are more organized with healthcare centers, primary healthcare centers. That's something that they've already done. It's important to understand that the number of consultations per doctor is much, much lower than the number that we do in France. I will let you calculate, but I think they have about 12 or 13 patients per day. So I'll let all of you make your own calculations. But so there's a problem of accessibility in general. In the Swedish system, they have a very high level of output and outcomes, but they do have a concern with accessibility in terms of there is a slight lack of capacity. So there are still some waiting lines, and that's true for primary care and for acute care. So there's constant reflection on the part of the regional authorities in charge of the topic in Sweden to see what alternatives they could put in place to alleviate these pressures and be more efficient without constantly increasing the funds and the finances devoted. That's why they started authorizing these online consultations. The example that comes to my mind is the example of a British GP, a dozen GPs who themselves invested in an internet platform to limit the number of physical visits and renew prescriptions online and give medical information online. And the rationale was to say, well, this allowed us to reduce by 30 to 40% the physical visits to our offices. Why did they do this? Well, in terms of incentive, they have a model which is per capita, so they have a real economic advantage in looking for these to improve efficiency. Should we go this far? Well, it is beginning in France, only for doctors. Pharmacists are beginning gradually, but not the other professions. When you're working as a team, some have advantages and others don't, or at least guarantees. But a GP today in France if you look at his remuneration with the objectives, if he's actually working in one of these maisons de santé, one of these doctors' centers, he arrives at 15% of a flat fee for the number of patients. So if a doctor wants to invest, he might say, well, it's to my advantage to increase my number of patients rather than see the same number of patients and reduce the number of repeat visits. And that's a notion that we don't have in doctors' training. And when I talk to my colleagues about this, they think I'm really strange. That's not the way we think. You could say, well, you could care for more people. They could have more access to care. Doctors might be open to this. That's why in Britain it is to their advantage because it is per capita. I know that in France they are trying to move in this direction, and thank God, because I think it's something that will encourage the reflection in terms of investment if it's linked to the number of patients rather than the number of acts performed. Now let's come back to the logic of the impact that this can have for healthcare professionals, and I'd like to conclude on this point. In your opinion, why will these professions be transformed in the future? Doctors, nurses. Are we going towards an industrialization that would be more intensified? Well, the transformation is already to learn to work in a complementary fashion and more collectively. Do per patient care, then each person has their own share. I think that's what's important. And then we'll learn to work together and learn, indeed, also to use these new tools in the common treatment path. Well, we have now healthcare coordinators. That's a new profession that's been invented. It's progressing. It's being developed. Coordinators are almost like clinic directors, but we don't call them directors. It's really in terms of the coordination of the team, forcing people to come and have coffee together, filling up the coffee pot, and meet with them because they're so stressed out and they're so overworked. And they help work with the relationships with the institutions. But healthcare coordinator is one profession, but there are other new professions that will develop, and we're continuing to experiment with this because the teams need some support. Other new professions may arrive. For example, real estate managers, advisors on a certain number, or consultants on a certain number of issues of medical strategy. I'm sure that those professions will be developing. It won't change the basic profession, but the doctor will spend more time making decisions rather than being the primary actor. Well, at the French Post Office, I imagine that this transformation has also been accompanied by the transformation of professions. Yes, all of the current professions, for example, even the mailman's profession has been completely transformed. They used to have a bag of mail and they were in charge of sorting the mail, but he now has a digital tool as well. And they provide services, in-home services. And so, yes, there is a transformation of the mailman's job around digital, around package deliveries and services given in the post office. You see, for example, today we are in charge of actually carrying out the highway code exams now instead of the driving schools. So services that are not provided sufficiently in France have been transferred to the post office because we are a service-based organization. And this is what we're trying to do in our transformation. We can work in an industrial fashion, but also in interpersonal relationships. And we know how to do that, and better sometimes than the state or the local authorities. And that's where we position ourselves. But new professions, I would say, well, with respect to all of your professions, given what we propose in terms of home services, for example, we have a new service called Taking Care of My Parents. This is the first level, not of healthcare, but of prevention, upstream prevention, because the mailman can go to visit the elderly or people who are over 90 usually, and you know that these people in France, I think there are 800,000 people over 90 years old, and in the future there will be close to 1 million. And, of course, they won't all. We don't need to hope that they'll all be in collective retirement homes or homes for the elderly. So that you won't have to treat these patients, so that the hospitals won't have to treat these patients in the emergency ward, too many of them coming into the emergency wards because people haven't anticipated things and they haven't been supported in their daily life, and to allow more prevention, and we can intervene every time it's necessary. This is where the post office can intervene, and I think it is a new profession, and we can include them in a chain of health care. Yes, you show this very well, that when we talk about the healthcare path, it involves all of the actors in a territory. The healthcare professionals, on the one hand, they have to open up to all of these other stakeholders and have more discussions with them. I define our job as an engineer along the healthcare path, and in our facilities, we've created these units that we call, they're almost engineering units on rapid recovery. And what do? Well, it consists of bringing together the teams, because today we really need to focus more on teamwork, but also we bring in the administrators to work on the typical healthcare path for patients, and then establish the data that we've recovered in terms of our outcomes, and then track them and share with the teams these results and the means to improve them. So it's really teamwork that we're doing here. It's very technical work, and it is coordination work. And what profile would you hire? Well, they're healthcare professionals. We really haven't brought in too many new human resources. We requalify our existing healthcare professionals with additional training, of course, on processes and organizations. But we do it a lot internally through internal promotion. And then how could we replicate this for thousands of patients without waiting for a renewal in the generations? How could we try to accelerate this transition? Well, I can't answer again for you, but I would say it's not sufficient in a company to decide something or even to train people. That's not sufficient. You need to explain over and over and convince people over and over. And each person involved must be convinced that it's useful, that he's providing, that they're providing a useful service, and that it's useful to provide it. If they're not convinced, if you haven't demonstrated this, if he hasn't done it himself, and there's not something positive that's happening with respect to the person who he's providing services to, that's we agree in our we call rapid recovery meetings. When we share results with the team, obviously there's a feeling of belonging to the team, and not, as we say, we go from being a stone carver to a cathedral builder, because we've given meaning to the teams, to everyone, for the results all along the healthcare path for the patients. While in primary care, the change has begun, we can consider that 10 to 15% of the professionals are already working in pluriprofessional teams, even if they're not at a level of industrialization that you can imagine. But there's a real gap, because we've seen that it was all the leaders in the profession who are working like this, and now we're arriving at it's no longer the same thing. We're going to have to render services to these people. So we need to industrialize this today. If we're going to attract these people, we can't have idealistic rhetoric of accessibility. People are comfortable the way things are. Doctors are comfortable with their profession the way it is. So I think the production of service, we need to really focus on that, I think, to convince people. And the generational replacement. So all the old guys like me will have disappeared from the system very soon. And young people do see the world in a very different way. And I think that's an opportunity for the patients. It's a good thing. Well, thank you. So industrializing is a necessity or even a moral duty, provided that we have the right notions behind the notion of industrialization. And the discussion we had is that it's the reverse of the dehumanization that people tend to associate with the term industrialization. Thank you all.